Thanks everybody for coming. It's nice to have so much support.
All right. And it's all yours.
Okay. Okay, so our team took on the task of trying to improve patient satisfaction scores among patients at St. Elizabeth. Here's our team. Myself and Bobby and Sean are going to present, and then I'd also recognize Brett and Prav and Doug and Jesse for all their help behind the scenes as well. So patient satisfaction scores, I think we all know that they are called HCAHPS, which stands for, since we didn't know this the first day, except for Carrie, Hospital Consumer Assessment of Healthcare Providers and Systems. So what this is a nationwide, publicly reported survey of patient assessment of their hospital care. The questions are all standardized. They're administered by third-party vendors. So for example, CHI Health contracts with a company called HealthStream. So when our patients are discharged, some of them are randomly called and ask a series of standardized questions. This was developed by CMS and also the Agency for Healthcare Research and Quality. Started back in 2006 as kind of voluntary participation and now is obviously nationwide. So the purpose of HCAHPS is to provide consumers with meaningful objective data to compare hospitals. Obviously, this is something that never existed before this. You can think of it more like the Yelp of going to the hospital. You know, now you can look up and see what people's experience have been like at a restaurant. That was impossible to do with hospital care before HCAHPS. It's also used now for financial incentives to hospitals. So these scores are really important to people administrating a hospital because there's big dollars at stake in terms of your Medicare reimbursement. And again, the real purpose is to enhance transparency, hoping that that drives quality improvement. So we had a problem at St. Elizabeth. We identified that our HCAHPS scores were simply not where we wanted them to be. We want them to be at a high level, so that we know that we have generated a great patient experience, which we feel will generate loyalty of those patients to CHI Health, as well as their family and friends and everyone they talk to, and would also help minimize any negative financial repercussions to our institution. The purpose was to create best practice around HCAHPS scores. What's the best practice? How do we improve them so that we can improve that hospital reimbursement, expand our market share through patient loyalty and referrals, and engage our patients, thinking that would likely lead to them being more compliant with the care plan that we outline for them, and also improve outcomes. There's been a lot of studies that show that HCAHPS scores are actually highly correlated with outcome data. And then, of course, all of this while improving the patient overall experience, so that third arm of the triple aim. So our vision going into this was to enable CHI Health, specifically here, to become recognized as a provider of choice and to be in the top quartile of patient satisfaction scores. Okay, Sean is going to outline what we did.
Thanks, Dr. Pullman. Thank you all for being here. So when we identified our problem, how do we go about setting up a project plan to fix what we saw as the issue? We narrowed down our scope, and we limited it to our hospitalist group and our adult inpatient unit west with those specific HCAHPS scores. And then the very specific physician domain questions, which we will review. So all the information I'm about to share with you, we put together into a PowerPoint that we shared with our hospitalist group on 2 separate occasions, one given by Dr. Perlman and one given by myself. We also continued to share our data on our HCAHP on a regular basis. We looked at each physician based on MPI and HCAHP scores to give everyone an idea where we were to start with. And it was really quite shocking, to be honest with you, not knowing any of this information before. It's a real motivator once you see those numbers. So what we are trying to do is to improve that top box score. We all want to be on the top, and that top box is what is very important here. Here are the specific questions that are asked by HealthStream on physician satisfaction. So they're looking at courtesy and respect. How often do you treat your patients with such? How well do the doctors listen to you? And then how do doctors explain things to you? Now, it's rated as always, usually, and sometimes /never. But when it comes to our actual rating, we want the always, because it's all or nothing in this situation. So this is our goal, is to get patients to say always on every question that they are asked here. So we want to engage our hospitalist group, and how are we going to do this? Our PowerPoint went back to the basics on research, and here's the Harris Poll research that what do patients look for in your physicians? It's all pretty basic. It's a kind, caring human being, basically. They want someone who's going to listen to them, someone who's going to take their thoughts seriously, show that we care about them. So reviewing that with our colleagues in our group is very beneficial. And another thing here is a lot of other basic things that we do, just to remind everyone. Do the same thing every day on a regular basis. Be courteous. Even though that this is our facility and we're taking care of these patients, let's treat them like this is their house. We're going into their room. Knock before you enter. Introduce yourselves. Explain what your purpose is. And most importantly is sit whenever possible. Research has shown that if you are spending 5 minutes with a patient and you're standing up, they perceive you've spent longer time with them if you just sit with them at the bedside. One of the things that we found is not all the hospital rooms have chairs or places for us to sit. So that's area of improvement. Always having some place for a physician to sit helps greatly. St. E's uses AIDIT. This is a very popular tool. You go into the room and say, I'm Dr. Sean Hansen. I'm your hospitalist. I'm going to be overseeing your care while you're here. Here's the goals for today. You have a CT of your abdomen. I'm going to come back and share the results with you. Do you have any questions? Okay. Give time for questions. Sit with them, explain things. We have a brochure that we give patients on admission. Part of this project is we started using these brochures a little more proactively with the providers. I'll give my patients this copy of this brochure. You can see Dr. Gillum sitting at the bedside talking with the patient. That's very key here. I circle my photo to let them know this is me. Here you go. I'll be taking care of you. I'll be your hospitalist. Again, reiterating and engaging physicians, reteaching, having patients teach back, answering all questions thoroughly, preparing them for their day ahead, explaining medications. That's all part of improving HCAHPS. And this is national data that's been collected to tell us what things can a physician do to help improve your HCAHPS scores. Every room has these boards in the room. And so another initiative is we ask the nursing staff and nursing aides to make sure that your hospitalist is clearly identified. It's a little thing, but it makes a big difference, especially when they're going to discharge. They've seen our name every day. If it's not there, we'll write our name up on that whiteboard, and so they can have a visual to link us to them. Here at St. E's, we have virtual nurse. We are piloting this virtual nurse now for CHI National, and this is a secret weapon for us. This is an additional nurse that's available to help the floor nurse. It doesn't take the place of them, but it's an added assistant help. They can continually reinforce the fact, Dr. Hansen's your hospitalist. I try to push the button when I'm in the room if I can get the virtual nurse on, let her watch my interaction with the patient, and then oftentimes my real value I've found is that they're able to explain things after I've left. Patients always come up with questions that after you've walked out the door. So it actually saves me time and it makes the patients a lot more comfortable, okay? 12 beds upstairs in the AIU West have this now, with plans to expand to the full AIU West later this month. And again, when a patient is discharged, we have started saying you may get a survey from HealthStream. And when you are surveyed, you will be asked to rate your physician. I am the attending physician that you're going to rate. That's very important because hospital medicine is complex, and we have a lot of colleagues and consultants in with different cases. There has been times when Dr. Perlman's been confused with Dr. Voigt, so we know that patients aren't rating the HCAHPS properly. So as much focus as we can get into them correctly identifying us, our scores are going to improve. And what we do then is give them another brochure at discharge, then reiterate who their hospitalist was. Bobby?
Hello, I'm Bobby Hawk. I'm also a hospitalist, but just of the teeny tiny patients. So I am a neonatologist, but HCAHPS scores do affect our practice also. It's not the patients that rate us, but it is their parents that rate us and how we interacted with them during their hospital stay. So the stakeholders for our projects, those with interests, shares, investments in what we are doing, with the administration, certainly they can benefit from improving our HCAHPS scores, but they also need to invest in it because it has been shown that having satisfied staff is the first step to having satisfied patients. The nurses and the hospitalists certainly were engaged in this project and big stakeholders in it. The hospitalists, obviously, as Sean has explained, were the key ones trying to influence their own scores. But very important to that is the nurses, not just the virtual nursing, but also the bedside nursing. Because I think we all recognize that the point of care in the hospital is the nursing care. And our scores as physicians actually can live or die based on the nurse's care at the bedside. And then the patients certainly have an interest in our own care and how we can improve it and how we improve our communication with them. So our original goal, as Sean said, was to increase our top box percent from 2 to 5%. The red line is what represents our top box, and that's the always scores. So did your doctor listen carefully to you always? Were you treated with courtesy and respect always? And did the doctor explain things in a way that you could understand always? So the September-October data are the pre-baseline data, and that average was 72% of top box, or 72% of always in response to the questions. After the intervention for November, December, January, that average was actually 89%. So we had a 16% increase in our top box scores. We were shooting for 2 to 5%. The other thing this graph illustrates is that a small change in top box scores can give you a very large change in percentile ranking. So the percentile ranking may be what gets visualized by consumers who are searching for us on the internet. And it's the top box scores that are really being looked at for our HCAPS and our reimbursement from CMS. So as part of value-based purchasing this year, we have $840,000 at risk from CMS. Our HCAP scores directly can get back 210 of that. But indirectly, those HCAP scores and that patient satisfaction spill over into all aspects of value-based purchasing. So we can get up to 75% of this just based on increasing our communication and listening and explanations with the patients. So what are the realized benefits? Number one, patient care is improved. And that's, you know, we are trying to change our behavior as physicians to influence survey scores, but the bottom line is the patients are truly benefiting from what we've done. The hospitalists are benefiting in that they are engaged more with the patients. The more we are engaged as providers, the more job satisfaction we do have. St. Elizabeth benefits as our HCAP scores for internal medicine patients rise, so do the scores for the whole hospital. And also for the internal medicine patients that are teeny tiny in the NICU, we can influence our whole hospital scores. And our team, this was a very successful project, and it was very interesting to work with a whole group of physicians, a lot of dynamics going on as we learned from each other and about each other with the different specialties and approaches. Lessons learned, engagement is required to improve satisfaction scores. Engagement of the doctors, the hospitalists, but also engagement of the nurses. And engagement of the patients, asking them to talk back to you actually makes them feel more engaged in that conversation and more participant in it. And then first engage the stakeholders. Identify that your hospitalists and your nurses are the ones that are going to have to put in the most effort to change this. Engage them first, and then the actual behavior change after that will be a lot easier. The next steps, how do we sustain this great improvement? Well, truthfully, there's always variability. There are good months and there are bad months. To sustain any process improvement, it requires feedback to those who are trying to improve or change behaviors or skills. So monthly and quarterly feedback to the IMS doctors, also to the little tiny IMS doctors. And then also, I think, feedback to the doctors how much money is at stake. I think it makes a difference to us to be able to see how does this really affect our outcome? How does this really affect me? So feedback with not just what our department scores are, but what's at stake here and how can I improve that component of what's at stake. Who owns this moving forward? I think every physician owns this moving forward. Certainly IMS has done a lot of work in one area. We can expand that within their department. Just a little bit of bleed over has happened in my department. I think our scores are improving just from being involved in this project and with my colleagues. Recommendations for future work. Expanding it to other IMS floors and patients will be not a very difficult task. Expanding it to other floors of the hospital will be an extremely difficult task. Because a group of employed physicians is easy to address all at once and encourage a behavioral change. A group of non-employed physicians are difficult to engage at once and even more difficult to encourage a change in behavior. So I think as we target improvement, we may just target service lines. For instance, we could target the 4th floor with delivering providers, FPs and OBs at an OB meeting. We could certainly target the pediatric providers from the newborn side. I think it will be much more challenging to see those scores improve. But things that we can do to improve that success will be to keep the nurses engaged, because again, the nursing component of it does affect our physician scores. And then improve the satisfaction of the employed physicians and the nurses both in the hospital, because when we can have more satisfied employees, we will have more satisfied patients. Thank you.
Very fine. Thank you very much. So, questions, observations, what would you like the team to answer? And while they think about that, I'd like to know, of the different challenges that you looked at, was there one particular challenge that was the most difficult to get through? Was it understanding what was involved or implementing it in any way that you would identify?
I think probably sustainability. You may notice we didn't have March and April on there. And they did drop off a little, not to our baseline, but they did. So I think people tend to be enthusiastic at the start of a project, but it's difficult to maintain that. It's also been a state of flux around here. I mean, I don't want to make an excuse for it. We need to keep it sustainable, but that's also been hard in terms of morale-wise to maintain a focus on this type of thing. So, Barry?
So, first of all, this is remarkable work, you guys. I think this is really great, and I appreciated your explaining the percentile, because the percentile rankings, everybody's getting good at this stuff, so it's all skewed over to the right. So a little bitty percent change is a huge percentile change.
Yeah.
And I think it's extra remarkable that you showed that improvement in light of the difficult milieu we've all been functioning in. I mean, you were sort of running in sand, so to speak. My question is, for you guys, it's obvious how you would get engaged. I mean, this is your project. How did you sort of bring your partners in, to get them excited about this? Because I'm not sure that physicians always just naturally gravitate toward this topic as, oh, wait, here's another great thing we can look at.
Yeah. I mean, our group, we're lucky that we have a very collegial group of people who want to do a good job, and that's just luck and happenstance, thank goodness. I think the other thing, as Sean pointed out, was individual data. That's a huge driver for physicians.
So you showed them.
We showed it, yeah. They could pull this by NPI number. Now, it's not 100% accurate. I tended to have way more attributed to me than anybody else, and that's simply because my name is on way more charts as the attending for Moonlighters, for example. But there's probably some correlation, and even if it was accurate or not, just to have something that's yours really makes you want to improve it. So I think that helped.
I have one other question. So this is in the hospital side. There's CG caps in the ambulatory world. And Bobby, you talked a little bit about how you spread this to another unit. Do you think there's some applicability to our ambulatory clinics in CG cap scores?
I think there certainly is. I have to confess, when I went into medicine, I didn't realize I was going into a customer service industry. But that's truly what it has become. We're not just scientists at the bedside. We must become customer service people. So I think we can. It just requires education, and I think physicians are competitive by nature, so we show our own scores, we find out what they are, we set a goal, and I think, establish that. It is possible to change that in the outpatient setting also.
I think going back to what Anna was talking about, education is probably one of the biggest things for physicians. We're not very good at just blindly going into a project and just doing something that someone tells us to do. But when you educate a physician and say, here's what we want to do and here's why we want to do it, you get that competition along with education, and we're pretty highly motivated people. So I think that really helps.
Yeah, really nice job. Nice to see the outcomes and all that. What do you think? What were the biggest changes you made? Do you think that made a difference? One or two big things?
I think the sitting down is huge. And even just kind of resting your rear on the radiator when there's not a chair, it just something about that body language is, I'm here for as long as you need me, and usually it doesn't end up being longer.
Did you get people to get chairs in the rooms then?
No. But we found a way to sit. I mean, you can sit on the edge of the bed and it pumps up and pumps, it's hard to concentrate, but there are ways.
There's an alarm going off.
There are ways to change your body language, even if you're not sitting. You're still relaxed, you're there to stay.
How about picture? Did it affect
The what's that?
picture, identifying?
The brochure. I think that's a big thing, and also, as Sean explained, writing our names up on that whiteboard. Because when you're in and out and they just hear it, but it's hard to remember, but if you see it written there every day, I think it gives you an identity. So I think those were probably the biggest things.
Yeah.
Anything else?
Do you think the nursing staff helped with this? Were they on board too?
Not as much. They were instrumental in getting our names written up there, but beyond that, we didn't involve them with any specific tasks other than just writing the name. Yeah.
So if I was a new physician coming in to the next class and wanted to do a similar project like you did, what would you say would be your top 2 things that maybe you would do differently?
I think probably more reinforcement. I think we did a great job at the rollout where we really got everyone to sit down and watch our PowerPoint. But I think you probably need more structured. Once a month, we're going to make sure everybody sees the data, not just an email, but like me and Sean showing them the data, kind of refreshing what we did to keep that sustainability. I think it's hard to be disciplined around that. There's, you get distracted with other things that come up. So that would probably be the key thing.
How fast could you get your scores back? Was it 2 months in the rear?
They come in waves, kind of every couple weeks, and then I would say about 6 weeks after the month is done, you have the final for the month. So every 2 weeks, we would get an update from HealthStream.
I'm thinking about your project process of connecting with each other, organizing. I don't know how well you knew each other coming into this, but how would you describe that process? Was it easy? Was it challenging? And what made it successful? Now, obviously, you guys have gotten to the point where you work together really, really well. Anything that you did that made that happen?
I mean, technology, obviously, we all live in different, I think we were in 4 cities trying to do this. 3 of us physically here at St. E's, but everybody else, Kearney, Grand Island, Nebraska City. So, having the ability to have voice conference calls and share things online, through a live meeting has made this doable for sure. So
I think another component to success of this was a very narrow scope and definition. I've had a lot of projects where I tend to want to end up establishing world peace. And to narrow that down to say this score by this %, I think really helped us focus our energies on the improvement.
I think we did a good job of divvying up the tasks too. Obviously, we had to do the stuff that had to be done here, but the other guys were great at helping with the PowerPoints, helping do research behind the scenes about what influences HCAP scores. So kind of realizing where each person's strength would be in this situation just based on geographic location and situation was helpful.
And anybody on the team can comment. What about it was painful in either the project or the process of working together as a team?
Sean, he's just hard to work with.
It's so obvious, there's always challenges, a little bit of pain. Anybody want to?
Time, I think, is the biggest thing. It's pretty hard to get 7 physicians to be in the same phone call at the same time, and we're never very reliable. Just ask my wife.
Any other pain points? What about any other comments or questions? Excellent. You've been
Okay.
outstanding.
Thank you.
Congratulations.
Thank you.